Hello students. So this video is a continuation of the previous video, which is the diagnosis and clinical examination, where we saw about extraoral examination. In this video, we'll be seeing about intraoral examination and functional examination. So coming to the first one, the intraoral examination. Intraoral examination basically is the examination of the intraoral structures, which involves hard tissue and soft tissue. Hard tissues are basically your dental structures, the different types of malocclusions, vertical, sagittal, and transverse malocclusion that can be seen in a patient, and the soft tissue examination, which involves the tongue, the mucosa, the palate, the gingiva, and the frenum. So all these needs to be examined. There are implications for each of these things, which we'll be discussing subsequently. First, we'll be starting with the tongue. So tongue is a very important muscle in the intraoral structures, as a part of the intraoral structures, and plays a major role in development of certain malocclusion. So any abnormalities with regard to the tongue in means of its shape or the configuration needs to be noted down before starting the treatment. The color of the tongue is generally noted to check if there are any inflammation or there are any underlying condition that could predispose a patient to some sort of abnormalities in the tongue, as a means of examining the medical condition of the patient. So first clinical examination, like it's mentioned, you have to look at the color and the shape of the tongue. Next, the length of the tongue. Why is it important? Length of the tongue generally not much affects the orthodontic treatment, but a larger size of the tongue, as you can see in this. A larger size of the tongue, particularly when it is low lying, can cause something called as a lateral open bite. In certain malocclusions, for example, as it's mentioned, class 3 malocclusions, the tongue is generally larger because the lower jaw is also larger. So the tongue is generally larger, and the tongue, as you can see in this image, lies on top of the tooth structures like this. So the characteristic feature of such tongue is the imbrications that is seen in the lateral border of the tongue. So the tooth indentations will be visible on the lateral border of the tongue when the tongue is slightly large. So one of the indicators, clinical indicators of macroglossia, is the lateral tooth imbrications on the lateral border of the tongue. So what happens because of this is when the tongue covers the occlusal surface of the molars, the lower molars does not occlude with the upper molars. So when the patient's tongue is moved, you can see a lateral open bite. So one of the important causes of a lateral open bite is a large tongue. So identification during extraoral examination and intraoral examination of this feature is very important. Next, tongue position. There are certain malocclusions which are affected by tongue positions. Improper tongue position can cause different types of proclination, open bites, and all sorts of different malocclusions. So based on Wright's classification, we can classify the position of the tongue into 3 classes. So first is class 1. Class 1 basically means the tongue lies on the floor of the mouth with tip forward and slightly below the incisal edge of the mandibular teeth. This is considered to be the ideal position of the tongue. Next is class 2. Class 2, the tongue is flattened and broadened, but the tip of the tongue is in normal position, which is slightly below the incisal edges of the mandibular teeth. Then there is class 3 tongue position. The class 3 tongue position is also called as a low-lying tongue. So the tongue lies at the floor of the mouth with depressed and the tip assimilated into the body of the tongue. How does it imply or cause any malocclusion? One of the major factors that helps in the development of the upper palate or the palatal arch is the tongue. When the tongue is positioned normally in the arch, the curvature, upper curvature of the tongue, as you can see, this is the palate and this is the tongue. If the tongue is depressed like this, the palatal development does not happen to a greater extent. But when the tongue is normally positioned, the upper palate also deepens, the depth of the palate decreases, and the palatal development happens normally. and hence the width of the maxilla attains the normal structure and the development of cross-bite tendency decreases. So, but when the tongue is low-lying, especially in cases where there are habits, for example, tongue thrusting, thumb sucking, where the tongue positioned is purposely flattened, like thumb sucking, when the patient puts the finger into the mouth, the tongue is prevented from touching the hard palate. So the tongue goes slow, the palate does not develop, and therefore, one of the common findings in such situations is a narrow maxilla. So tongue development is extremely important. Tongue position is extremely important for the development of a normal palate. So you have to understand and find out what is the tongue position during your clinical examination. Next important thing is a lingual freedom. So high lingual freedom, also known as ankyloglossia or a tongue tie, is important because it can cause a little bit of recession in relation to lower anteriors and can also cause some amount of crowding in the lower anteriors. And it prevents the mobility of the tongue, and hence there will be associated problems during speech as well as deglutition and mastication or deglutition. So checking the position of the lingual freedom is also very important. Next, labial freedom. One of the most important causes of a midline diastema, most common causes of a midline diastema is a high lingual freedom. So a heavy lingual freedom can cause midline diastema or generalized spacing. This, uh, if it is being treated, once the treatment of the spacing is complete, we have to undergo something called as a freenectomy. Freenectomy is done post space closure, preferably than pre-space closure, because the scar tissue that forms during the freenectomy prevents relapse. So generally freenectomy due to a high frenal attachment should be undertaken after the space closure. This is a very important one mark question. So they'll ask you when the freenectomy is indicated, during orthodontic treatment or before orthodontic treatment or after the space closure. Generally, freenectomy is indicated after the space closure, before removal of the fixed appliance. After space closure and before removal of these fixed appliance. So this helps in adding more retention or prevents the relapse of the malocclusion. So there is also one characteristic finding in a high frenal attachment, which is seen in an IOPA radiograph. In your periapical radiograph, if you take the periapical radiograph of the incisal region, a characteristic notch will be seen in the interdental bone, indicating the attachment of these frenum fibers. So a high frenum clinically and a notch in between the two incisors in the interdental bone radiographically confirms the presence of a heavy frenum. So this frenum can be identified clinically using something called as a Blanche test. So Blanche test is a very important one mark question. What we do is we pull the upper lip upwards and backwards and create tension in the frenum. With your mouth mirror, you have to check in the incisal papilla region. When you see in the incisal papilla region, if there is a high frenum, there will be blanching, or the color of the mucosa will change from pale pink or red to a more whitish shade. So this is called as a Blanche test. High frenal attachment is confirmed by means of a Blanche test. So this is a one mark question. What test is used? You can mention it is a Blanche test. Another frenum issue is your mandibular labial frenum. So high mandibular labial frenum, as you can see in this image, can cause labial recession. So removal of high frenum can help in maintaining the periodontal status of the lower anteriors. So this is regarding your frenum. So with regard to labial frenum, you need to know what is the procedure done to after space closure, frenectomy, and when it is done. The second is what is the test done to identify a high frenal attachment, and also you need to also know regarding the presence of a notch radiographically in patients who have a very high frenal attachment. Next, we move on to gingiva. So gingiva is a very essential part of orthodontic preclinical diagnosis because inflammation can indicate a different kind of things. So, because one important reason is poor gingival hygiene is an indicator that the patient will not maintain hygiene during orthodontic treatment or is going to develop some sort of complication during orthodontic treatment. So, adequate oral hygiene instructions and management of the gingival condition and the oral hygiene prior to orthodontic treatment is very, very essential. Hence, knowing the gingival issues beforehand is very important. So in this image, you can see that there is gingivitis. However, the patient might not have a lot of uh, plaque or deposits. This could be because the patient is a mouth breather. Patient having very short lips, incompetent lips, and they're chronically breathing through the nose, the gingiva generally, especially in the anterior region and the upper anterior region, gets inflamed. So this will kind of point us towards the etiology of the malocclusion. Patient can have other features, may not have other features, or this could be the only feature of the mouth breathing habit. So it is essential to know the different types of gingival enlargement, even if there is no additional factors like calculus or plaque. If the patient is having amount of gingivitis, especially the only in the anterior gingiva, it is important to rule out mouth breathing. Next is patient who are undergoing anti-epileptic treatment using anti-epileptic drugs. This is a phenytoin-induced gingival hyperplasia. So you need to know about the medical history of the patient for diagnosis. Next is occlusal trauma. Patients having severe malalignment might have some sort of gingival issues, especially in severe crowding, or in this case, as you can see, in severe crossbite cases. So patient will have some amount of gingival trauma here. So there is a recession and there is inflammation in the upper gingiva also. So relieving the trauma, just by relieving the trauma by orthodontic treatment, will take care of the gingival findings. This is regarding the gingiva. Next, we go into the palatal mucosa. Important things we need to know about the palatal mucosa is any sorts of pathological swelling if they are present, any ulceration or scar tissue formation. So any bulge that can be seen in the palatal mucosa needs to be noted down. So you can see in this image, the patient has a canine here, however is missing a canine in this region. There is a palatal bulge. This can note that the canine is impacted. So palatal bulges that are seen unilaterally, if the tooth is missing clinically or there is a retained deciduous in the intraoral findings, then you can suspect an impacted tooth even before going into a radiograph. So this is one of the important clinical guidelines to check for any missing tooth and for checking the palate. Next is presence of mucosal indentations. You can see here, this area, the palate is being traumatized. This is mainly because of a deep bite. So deep bite is causing palatal trauma, which is a clear indication for orthodontic treatment. This is called as a traumatic deep bite. So palatal ulcerations or indentations can indicate the deep bite is traumatic and there is a need for orthodontic treatment. Next, as you can see here, there is a scarred palate here. This is indicating of a treated cleft lip and palate surgery. So patients with cleft lip and palate or isolated cleft who does not have a cleft lip, you are supposed to take a note of the palatal scar tissue and ask for history if the patient does not elicit by themselves. So this is regarding the soft tissues. Now we move on to the hard tissues. Hard tissues is quite straightforward. You look for the number of teeth that is present, the number of teeth is missing, or are they impacted or unerupted, which can be evaluated comprehensively using a radiograph. Next, the presence of caries or any pathology. Before undergoing orthodontic treatment, the management of caries, the management of gingival issues and periodontal issues have to be carried out before undertaking orthodontic treatment. It's very, very important. So even if so, it is our responsibility as students or orthodontists to note for any of these issues, to address them and then take the patient for orthodontic treatment. Whatever is the issue has to be addressed first, then only the orthodontic treatment can be carried out. Next, the molar, canine, and incisor relationship will be noted. This is of clinical significance. All these three has been classified as class 1, class 2, sorry, class 2 and class 3. Class 1 molar, incisor and canine relationship has to be classified. Next is the amount of overjet and amount of overbite has to be recorded in millimeters. So overjet is the horizontal distance between the upper incisor. This is the overjet, horizontal distance. The overbite is the vertical overlap. You measure from the point of contact of the upper incisor to the lower incisor edge. So this vertical height is called as overbite. Generally, normal overjet and overbite is 2 to 4 millimeters. If it is more than that, it is called as if the overbite is more than 2 to 4 millimeters, it is called as a deep bite. If there is complete closure of the overlap of the upper incisor without any visibility of the lower incisor, it is called as a complete deep bite or a box bite. This is commonly seen in class 2 division 2 situations where the upper incisors completely covers the lower incisors. The lower incisors will not be visible at all. And irregularities, if there is any crowding, if there is any spacing, and you also have to mention the amount of crowding and spacing in millimeters. And arch form, how is the arch form? Is it U shaped, is it V shaped, or is it square shaped arch? Is the palate deep? All those things you need to isolate in needs of hard tissue assessment. So this is regarding the intraoral examination. So next, we move on to functional analysis. So we talked about the extraoral examination, how the patient, when the patient walks in, you see the extraoral appearance, the face, everything. Next, you move on to the intraoral. We have examined the hard tissue as well as the soft tissue. Now we move on to the functional analysis. So orthodontics is not just about keeping the teeth straight in relation to the face, in relation to itself, but it is also required in certain situations where the function is also affected. There are situations, malocclusions can cause functional disturbances. There can be difficulty during speech, there can be difficulty in respiration. For example, the patient has a mouth breathing habit, or for in some situation the patient might have problems during eating, and all these things needs to be addressed. To address things, you have to do a function analysis to check if the functions, basic functions, are happening properly. So in functional analysis, there are 4 steps. The first is assessment of the postural rest position and assessment of the maximum intercuspation position. When you assess that, you can assess the path of closure. In certain malocclusion, the path of closure slightly is altered. We'll discuss subsequently. Then you examine the TMJ and also few functions, orofacial dysfunctions that you generally encounter during an orthodontic procedure. So this is a very familiar topic, I guess, for all of you, because postural assessment of postural rest position, you do it in your prosthodontic management also. For assessment of the postural vertical dimension, we generally use assessing the postural rest position. There are basically 4 methods to assess the postural rest position. The first is the phonetic method, the command method, non-command method, and combined method. So we'll go into what these are. Phonetic method. So postural rest position, what does it exactly mean? Postural rest position is when the muscles are completely relaxed. When the patient is at the maximum rest position, or the muscles are at the state of maximum relaxation. So how do you get the muscles to maximum relaxation? The first technique is ask the patient to say MMM or Mississippi or Emma. So after, when they say it after 2 to 3 seconds, the muscles automatically relax and come to a relaxed position with the lips slightly parted. So that is the postural rest position, where the teeth won't be in contact, but the lips will be slightly apart and the muscles will be at a state of relaxation. So that is the phonetic method. The second method is the command method. You ask the patient to open their mouth, you ask the patient to swallow. So once they complete their function, they will automatically come to a postural rest position. So generally we ask the patient to just swallow your saliva. So they'll swallow and they'll come to a rest position. So you record the rest position at that position, at that point. Next is the non-command method. So in this technique, what you generally do is you don't ask the patient to do anything. You get on with your work. You just observe the patient. One, they will automatically come to a relaxed position. So on that position, you just make watch the patient carefully and then note down the method. And we can also do a for the best reproduction of the postural rest position, the combined method. You mix all of these techniques to get the patient to a proper postural rest position. So what do you do after getting the patient to postural rest position? So there is something called as path of closure. So, path of closure is the point where the patient from the position of postural rest comes to a position of maximal intercuspation. So, why is this important? There are something called as functional disturbances. Due to some sort of malocclusions, the patients might develop functional disturbance where the teeth will be having, especially if there is any cross bite or there is an anterior open bite. There might be some sort of prematurities, tooth prematurities, due to which the patient will not be able to bite there. So they will shift and bite somewhere else. So that can lead to some sort of asymmetry or a presence of a cross bite, that it is primarily because of a functional disturbance. So we need to assess the path of closure in such patients. So we need to get the patient to a postural rest position and then ask them to bite. So from the rest position, they bite. The normal path of closure is, you can see in A and B. This is the intercuspation. From the postural rest, it is upwards and forwards. For everybody, the normal path of closure from the postural rest position to the point of maximum intercuspation is upwards and forwards. In some malocclusions, it can be upwards and backwards, or in some situations, it can be twofold like this due to the interference. So, we need to know what type of path of closure does the patient have. Next image, we can see in certain malocclusion, the path of closure will be different. As you can see in the first one, upward and forward is the normal path of closure in patients with class 2 division 2 malocclusions. So let me come to class 2 division 2. What is class 2 division 2 is the patient will have a class 2 molar relationship. However, the incisors will be retroclined. So the incisor will have something called as an overclosure. It will prevent the lower jaw from growing forward. That is the important reason the patient will have a mandibular retrognathism. So when you free the upper incisors, the mandible generally glides forward. But in patients who have been with this class 2 division 2 for a long time, they would have developed a altered path of closure. So initially, if the incisors are retroclined, generally the mandible is supposed to go forward. But since the incisors are retroclined, it will go forward and then go backward. So this is called as upward and backward path of closure. This can be seen in this image. So due to the retroclination of the incisor, the mandible, instead of going forward, goes upwards, hits the incisor and goes backwards. So this is called as upward and backward path of closure. It is seen in class 2 division 2. So these are very important MCQ questions. They can be asked. Upward and backward path of closure is seen in which malocclusion, or what type of path of closure is seen in laterognathia or laterocclusion. So all these can be asked. Next, upward and laterally with midline shift only in the occlusion generally is seen in posterior crossbites. So if there is any posterior crossbite or if the maxilla is constricted, the mandible, which is normally sized, will not be able to fit it. So generally how it fits so that there can be maximum functional efficiency. So it can either fit like this or it can fit like this. So when the maxilla is narrow, the mandible shifts on either side laterally and fits into the position. So it will be visible as a midline shift. So up when the patient moves from the postural rest position, you will see the midlines are coinciding. The midline shift is not due to any dental issue, it is due to a functional shift. So when the patient is in rest position, if the midlines are coinciding, and when the patient goes to an occlusion, when the midlines are shifted, it is something called as lateroocclusion. Lateroocclusion, or also known as functional asymmetry or functional shift. So this is called as functional shift or lateroocclusion. When the midlines are coinciding at rest position but shift when in occlusion, it is called as lateroocclusion. But in laterognathia, the midlines will be shifted both in rest as well as the occlusion. That is the difference between laterognathia and lateroocclusion. This is also a very important viva question and also a 1 mark question. So in laterognathia, what happens is that there is upward and laterally midline shift, but this is due to true skeletal asymmetry. This is not due to a functional disturbance. Laterognathia is due to a skeletal asymmetry. In certain situations where there is anterior crossbite, the patient will have a upward, forward and a forward bite, as you can see in this image. When there is an anterior crossbite, the upper incisor will be retroclined. It moves upwards, hits, and again moves forwards and bites in the crossbite. So upwards, forwards, and forwards is seen in pseudo class 3 and anterior crossbites. So this is regarding, we discussed about little bit about the postural rest position and the path of closure. It's a very important functional examination you need to remember. Next is the examination of the TMJ. So how do we start with the examination of the TMJ? It's a very important short notes for final year students, and a very important 1 marks do come from TMJ examination. Inspection, palpation and auscultation. Inspect for any asymmetry. If there is any asymmetric positioning of the condyle, are there any redness around the condylar area? Next is palpate. You keep your tip of your fingers on the condylar prominence near in front of your external acoustic meatus and check for the condylar movements. You check for tenderness, you check for synchrony or coordination of the condylar movement, and also you check for any associated clicking sounds that you could feel, and also you have to palpate all the muscles of the mastication for any tenderness. Next is auscultation. You use a stethoscope to auscultate for any signs of clicking and crepitus. So you ask the patient to open the mouth and close the mouth and check when the clicking or the crepitus is seen. Is it seen during opening the mouth or is it seen during closing the mouth? So this can indicate different types of TMJ disorders. If there is any opening click, the TMJ disc displacement, is it with reduction or without reduction? So all these can be classified only when you know when the click is seen. And also you also check for any the click is located for the synchrony of the click. Is it clicking later? Is it clicking during the movement? All those things you need to look for in auscultation. This is regarding the TMG examination. Next is functional examination. First is assessment of swallowing. So basically we need to understand two types of swallow is generally present in patients. One is a somatic or a mature swallow. The next is a visceral or infantile swallow. First we'll come to mature swallow. What are the features of a mature swallow? First is there is contraction of the muscles of mastication. This is a mouth closed swallow. This is how a normal person swallows. Whenever we swallow, we do not open our mouth and swallow. We have to close our mouth to create a peripheral seal, and then we create a negative pressure for the swallowing. And when we swallow, When you palpate the muscles of mastication, the muscles of mastication are supporting the mandible so that the swallowing process happens. So this is a mouth closed swallow. However, in a visceral or an infantile swallow, what happens is the perioral muscles are active. This is generally seen in infants who are taking breast milk or having feeding using a bottle. So they bring the tongue forward, they keep the bottle inside their mouth, and they start sucking. So the sucking is helped by the perioral muscles. So perioral muscles are the ones supporting the mandible, and it is not the muscles of mastication. As and when the dentition develops, as and when the infant develops into a bigger individual, the muscles of mastications are developed. So by 1 year of age, the child should be able to have a mature swallow. If the child does not have a mature swallow, still during swallowing, the tongue is coming out and the swallow is happening because of the contraction of the perioral muscle, that is the orbicularis oris, then it is called as a infantile swallow. But patients who have some sort of anterior open bite or tongue thrusting habit also will have the tongue forward when they are swallowing. But it is not exactly infantile swallow. Not everybody has infantile swallow. Infantile swallow is a very rare condition. It is seen in some sort of cerebral diseases only. It is not a very common finding, but you do see in many patients with an open bite, they bring their tongue forward and swallow. But one important difference between mature swallow and infantile swallow, like I said before, is the involvement of the muscles of mastication. Even when they are bringing the tongue forward and swallowing, it is their masticatory muscles that is going to contract, not the perioral muscles. They are just bringing their tongue forward because the anterior part, due to the open bite, it is open, or because of severe spaces or open bite, they have to seal the anterior opening. So it's just a habit that they are bringing it forward and swallowing normally, because there is an active contraction of the muscles of mastication and not the perioral muscles. So if you have to differentiate mature swallow and infantile swallow, ask the patient to swallow, palpate the temporalis. So when you swallow, the temporalis contracts, the masseter contracts. So you know that that is not infantile swallow, it is mature swallow. This is will be positive even in patients with tongue thrusting, because it is called as tongue thrust swallow, but not a infantile swallow. So patients who have open bite, all you need to palpate is the muscles of mastication, either in the temporalis region or the masseter region, so that when they swallow, you will know what muscles are contracting. If there is no contraction of the muscles of mastication and you are able to see the perioral muscles contracting, then it is infantile swallow. The difference between mature swallow and somatic swallow is a very important short notes if you're a final year, and few questions do come from 1 marks for this in this chapter also. Next is the evaluation of respiration. There are two types of respiration: oral respiration and nasal aspiration. Patients might have, usually we have a oronasal respiration, because not all the time our nasal passages are clear. If we have a cold, if we are having some sort of flu like symptoms, we do have a transient oral respiration, but it goes back to normal when the oral mucosa is cleared or when the inflammation is subsided. But patients who have habitual or due to some another anatomic factors or pathological factors constantly breathing through their mouth, so oral respiration needs to be differentiated. So what are the methods of assessing? There are few chair side tests that can be done to assess the breathing, whether it is through the oral passages or the nasal passage. The first is the use of a mouth mirror, or it's called as a mouth mirror test. Use of a mouth mirror test. So take a double-sided mouth mirror, keep it near the nose and the mouth region. So when the patient breathes through the nose, there is a fogging of the mirror from the nasal area. If the patient breathes through the mouth, there will be fogging of the mirror near the oral area, that is their mouth. So with the which area of the mirror is getting fogged, we'll be able to make out the breathing pattern also. Another technique is something called as a butterfly test. What we do is take a cotton fiber and place it like a butterfly near their lip region. So the fluttering of the cotton fibers near the mouth will indicate they are breathing through the mouth, and if they are fluttering near the nose, it will indicate they are breathing through the mouth. Sorry, in the nose. Next is a water holding test. If the patient is an obligate mouth breather, ask the patient to fill the mouth with water and close it and ask the patient to breathe. If they can breathe through the nose also, they will be comfortable. But if they are chronic mouth breathers, they will not be able to hold the water in their mouth for a long time without breathing. So these are three very simple chair side techniques to give you an idea of whether the patient has mouth breathing or not. But these tests, like it is mentioned, are not very reliable because there are sometimes the patient, due to anxiety, can breathe through their mouth. So we need to do something called as a nasal resistance. So we can go to an otolaryngologist and assess if there are any structural deformities in the nose, is there any septal deviation, or if there is any nasal polyp or inflamed inferior turbinate that could cause some sort of nasal resistance and prompting the patients to breathe through the mouth. So nasal resistance test is the final method in which you can exactly compute how much the patient is breathing through the nose or the mouth. So that's it regarding the intraoral and functional examination. Thank you.